Ladies and gentlemen, good morning. Thank you for being here listening to this webinar. I want to thank, first of all, the B&B Dental, the B&B Dental family for inviting me for this lecture. I called this lecture Preserving Nature because we're going to talk about a technique, a surgical technique that we perform every time we have to extract a tooth to insert an implant or to maintain the three-dimensional architecture of the alveolar ridge. This technique allows us to maintain, as we can see in this picture, the three-dimensional volume and especially the bundle and the buccal bone every time we have to extract the tooth, and so we have to expect during the healing the resorption of the buccal plate and the modification of the hard and soft tissues around the implant. Here is another example where we can see how this technique let us to maintain, because the first implant is we use this technique in the first implant, but in the second and the third implant we only did the socket preservation and the blood clot. So the difference is evident, and only in the first implant we can achieve the same resorption rate on the buccal aspect. This technique is called, for the common using, it's called socket shield. We know that the socket shield actually is only a under category of a bigger group that is called partial extraction therapy, and but all of us know this technique about with this name. I'm very happy to use this technique because compared to the other GBR techniques or socket preservation technique, this for me is the best, because to achieve the maintaining of the initial architecture of the bone and on the soft tissue of the patient in a natural way. We'll see later how it works. To start this lecture, I want to introduce the concept that in this article from Daniel Buser, 2017, they did a review or and decision-making in article about what we can do in the extraction site, post-extraction site in the single tooth in aesthetic area. And the first important thing that we have to assert is that the aesthetic outcome and its long-term aesthetic stability is the first and of paramount importance in what patients ask to us when they come to our office. Of course, followed by proper function and phonetics. So when we have to extract the tooth and insert immediately the implant, or we have to maintain the pontic area, we have to reach one goal, that is the one that we call restitutio ad integrum. And what we know from this article, we know that the 80% of the cases of post-extraction site in an implant in aesthetic area is from type 2 group. The other groups are immediate implant or GBR with the same implant at the same time, that are considered advanced surgery. So for the 80% of the cases, we actually wait for 8 weeks, and then we go for a delayed implant, and actually we deal every time with the resorption of the alveolar bone. And the only reason we can insert the implant in an easy way is because in this type 2 group we have bone apically to the implant to achieve primary stability. Why we have this situation? From Arroyo and Lind, 2005, we know that the bundle bone is strictly related to the presence of the PDL, and they did a study and a histologic study in dogs, and they saw that if when we extract a root and we insert an implant or we don't insert the implant, the difference in 3 months is that we always has a crestal resorption, horizontal, a huge horizontal resorption, and a little of vertical resorption. And this is not changing if we insert an implant or we don't insert an implant. So actually, after 4 and 8 weeks, what we deal with this situation where we raise a flap, we full thickness flap, we insert the implant, and then we go ahead with the GBR and with the biomaterial membranes or a connective tissue graft. So I want to start this lecture about the socket shield or the partial extraction therapy with this article that signed from me times zero in this trip with this technique. It was May 2018 when I went to Milan in a daily course with Owe Gluckman. It was invited by Dr. Marco De Gidi, and we were confronting each other about this technique, and I already heard about it, but at that time for me was really the time zero, because for the first time I had from the author, one of the author of this article, I had the first step, the first indication and protocols about the techniques, how to cut the root, how deep to cut the root, which is the width of the shield that we have to maintain, and what is the correct insertion of the implant, and the prosthetic consideration about these techniques. And especially this was very important to me. It was to hear that there were at that time already a lot of literature about this technique, especially this article that from these authors that were Gluckman, Salam, and Dutoit, where they actually were talking about 128 socket shield cases with 4 years follow-up, with the survival rates that were the same of the post-extraction immediate implants. So for me, it was the first time I heard about a long-term follow-up about this technique, and it was for me the beginning, the start of this technique. After that, during the last 2 years, I had the fortune, I was lucky to meet many doctors that are masters on these techniques, like Maurice Salamas, Niezana Polu, Data Care, Howie Glockman, and Ziv Mazur. And they are from the Dental XP group, and which I'm very proud to be a member also. And they founded, the Team Atlanta founded a group of 19 people from all over the world to study and to actually write the guidelines for this technique. And we have also between them one Italian doctor, that is Dr. Armando Ponzi, and I have also many colleagues here in Italy, which we confront each other every day about our clinical cases that are Nello D'Ambrosio, Davide Tagliaferri, e Andrea Grassi, Massimo Natale, and the others Italian doctors that we are very proud utilizer of this technique. So actually what I did when I actually realized that this was one of the technique that I liked more, I went to read the literature, and I found out that from 2010 to 2020, actually a lot of articles were written during the years until to reach a number of articles in the last 3 years about the technique. About the maintaining the root inside of the bone when we have to decide to extract or not a tooth, we have in the literature on the by the the 50 and 1950, some authors describe the technique to maintain the root under the mobile denture, total dentures. But in 2007, Salamos Brothers and David Garber wrote this article when they were considering and to maintain the root under the pontic area in the aesthetic zones. So this was the first time they actually standardized the technique, and they suggest the protocols how to cut the root, that it was at the crestal level with the concavity and about 2 millimeters from at least 2 millimeters under the pontic element. And also they suggest to insert connective tissue graft to protect the area of the root submergent therapy. In 2010, Ulcer and Renzur, they did the first article that is considered the time zero of this technique, of this socket shield technique, that is that it was an animal histologic evaluation about naturally healing socket or extraction with keeping the shield into the side. So actually they saw histologically that between the shield and the implant, there was bone formation and cement formation into the internal area of the shield, and when the threads of the implant were in contact to the shield, the cement was growing on the titanium surface also. So they saw that there were no inflammation and no resorption of the shield and no resorption, especially of the bundle bone. In this study, they used amelogenin, and this was not used anymore in the actual protocols of the technique. And in this article, the height of the shield was 1 millimeter above the crest, and this also is something that is changed um, in the last years. Now the guidelines are to to trim the shield until the bone level. We'll see later better these informations. In 2016, 2017, Gluckman, Salaman, and Dutoit, they did these two articles where they actually introduced the term of partial extraction therapies. In these two articles, they did distinguished groups. So they divided all the partial extraction therapy in under groups. Like the one was this root submerger technique on 2007 from the article of 2007. The second group was the socket shield from the article of 2010 of Ursuler and Zur, and then the Pontic shield. The Pontic shield is it was considered with the biomaterial, but there's another kind of Pontic shield that is the Glocker technique, that is with collagen into the gap, with no biomaterials. And then Kahn in 2013 described the technique to keep the interproximal shield to maintain the bone peaks interproximal in the interproximal area where we have to extract the tooth. Here I designed the three examples, and we can see here in the root submerged technique actually we maintain all the PDL in contact with the root that is maintained under the crestal bone. And here in the socket shield we can see that the shield is maintained. We can insert the implant, we can leave a gap between the shield and the implant, and then we keep the space for the prosthetic elements. In the pockets, in the Pontic shield, finally we can maintain the three-dimensional architecture of the bone and the soft tissue by maintaining only the shield and cleaning all the apical area and leaving the cloth or the biomaterial inside. On 2016, we see that in same authors, Glockman, Salama, and Dutoit, they describe better how to manage the Pontic shield of the root submerged technique. In particular way, the Pontic shield. So they describe the technique. It is a case series, so they have some different situations, but commonly they utilized every time biomaterial inside the socket and different ways to close coronally the socket. So they had some cases with using membrane. They had some cases using connective tissue graft, like with the socket seal technique, or the best behavior was from the connective tissue graft Zucchelli's style with the sockets with half thickness flap into the buccal and the vestibular area to close perfectly the Pontic area. In this article also we start to see what are the indication for the Pontic shield or the root submerged technique, that is to have intact buccal bone. The roots are to be stable, and the tooth are to be or vital or with a good successful root canal therapy. After that, it's important that the root they have not to have periodontal intrabony defects. One of the most recent articles is from my friend Udata Kher and Dr. Kumar, and is from the Journal of Indian Society in Temporodontology. And here we have an example, and we are very well described all the steps that we have to follow to perform this technique. The first step is to cut the crown horizontally at the gingival level, and then with the not diamond bore, with the surgical drill, we can bisect the root vertically in the mesiodistal direction to separate the root from, and our goal is to keep the lingual part of the root with the apical, with the apex away from the side. and this is very important to me. Is from my experience, the first important thing is to um, avoid to do the mistake to leave the apex inside of the socket. So this is the most important thing. So, and this is very important to study and to look at the CBCT to understand how we can direction the first drills to reach the apex and to not damage the buccal plate, but still to be sure to clean very well the apical area of the socket. After that, we have to reach the goal to have the length of the shield about two-thirds of the original length when we cut the crown at the gingival level, and the width of the shield should be 1.5 to 2 millimeters. And of course, we have to remember that every time we have to perform a bevel to let the prosthetical spaces and to let the soft tissue to organize in the best way and to be stable in the time. Of course, the prostheses have to follow this design with the S-shape profile so we can have this space maintained with the prosthetic components. The third step is very important also, that is to place the implant in a correct three-dimensional way. And we can use the guided surgery or but commonly we have to think in a prosthetic way. When we have to insert an implant, we already have in mind which is the prosthetic project of our rehabilitation. So, what we know also from this article and from the authors in these years is that when we have a gap between the shield and the implant, we should have a gap at least 1 millimeter, 1 and a half, and this suggested that when it's higher, for example, more than 3 millimeters, it's suggested to insert biomaterial to not allow the soft tissues to migrate inside of the socket. Finally, we can finalize the prosthesis with screw retained or cement retained. It's not a big difference. The only difference is the management of the excess of cementum. So this is a very important aspect, and we have to understand that we have to be very careful about where are we going with the the marginal crown inside of the gingival margin. It is suggested to be at least a maximum 0.51 millimeter. This is my another of my cases when we can see where we can see that the first step on the left is to cut the crown horizontally, and when we have posts inside of the root, we can go around the post. My friend Udata is suggesting to go lingually, and I did this buccally, and I understand it's more difficult and it's most risky. So the guidelines are to start from the lingual part. But what this was these were my first cases, and so I went like in this way, and I was able to reach my goal, that is to pull out extract the labial part of the root, and how we can see here very well, the apex is totally out with the labial part. If we cannot do that, we have to be very careful with our drills to uh, to leave to drill all the and to clean all the apical area of of our root. So this is the way that we can insert the implant. We find primary stability in the apical area. And so these are the same rules of an immediate implant, you know? But the only different end is that we keep this little part of the original um, root of the patient to maintain the bundle bone, so the very thin buccal bone that we have in these situations. Sometimes we can do, of course, we can do the same things in the molar area. Is more advanced. It's more difficult to perform this kind of socket shields, but we have in literature also some well described techniques to do this, and the principles are the same. We maintain, especially the the, the buccal aspect of the root, but of course we can also maintain the distal and the mesial to maintain the interproximal peaks to preserve papilla like it was natural tooth. Gluckman, Nagy, and Dutoit also talk about this, how to manage the shield to gain space, and especially in the internal aspect of the shield. Here we can see how is designed the shield that is trimmed at the bone level, and then we have the bevel to allow the prosthetic S-shaped profiles to let the tissues organize, and so we can have this chamber space for the tissues. In my practice, I used to use the countersink, for example, the B&B as a countersink that we can use to verify if we can use the multi-unit abutment when we do tilted implants, and so we can see or use the countersink um, to to drill the bone that doesn't allow us to insert the MUA because maybe it's above the implant platform. And another trick is to use multi-unit abutment and try to see if they fit well. If they fit well, means that we have enough space or we control by eyes to see if we really have the space we need um, to insert our prosthesis. Here is an example, another example of a socket shield technique, and I wrote for you all the numbers that we have keep in mind to perform this technique. 2/3 so is the length of the root that has to be measured when we cut for the first time the crown horizontally. 8 millimeter is a value that Baumer, Otto, and Ulzerer will see in an article in a while. That is the minimum length they suggest to keep for the length of the shield of the socket, the buckle shield. 1/2 is 0. The half is the half of the width between the root canal and the buccal aspect of the root. And we can also consider the 0.25%, 1/4 of the diameter between the buccal and the palatal aspect of the root. So is or 1/2 or 1/4. Or we can also consider that the shield has to be at least 1.5 2 millimeters. So these are many ways to consider the problem of the width of the shield. Another aspect that we can also afford is to do the socket shield even when we have little small periapical lesion. Like in this case, the important thing is that we have apical bone to achieve primary stability for our implant. And of course, when the jumping gap is more than 3 millimeters or around 3 millimeters or more than 1.5 millimeters, we can use biomaterial. And like we did in this case, we did use biomaterials in the gap and in the periapical area. Here is the suture, and so we can go ahead with the prosthesis. What are the changes that we have in the soft tissue? This is a very beautiful article from the Baumer, Zur and Ulzerer, and this is the article where they actually talk about the optimal length of the shield that is going to be at least 8 millimeters, like you can see in this picture. And the most important thing of this article, and that is a radiographic and volumetric data after 5 years. They used an intraoral scanner to understand which were the changes of the soft tissues at the level of the crown that they inserted with the immediate implant with the socket shield technique and the adhesions tooth. The most important things are these two graphics that when they saw that the main value of recession was 0.37 millimeters at the level of the implant, but the most important thing is that after 5 years, if we look at the adhesions teeth, we have the less recession at the implant level in comparing to the adhesions tooth. And another article is considering what happens to the soft tissues is from Mitzias and Sorpas in 2020. This is 2 years follow-up, and here the tissue change was 0 millimeters. We have to say that the authors they perform a socket shield technique that they call root membrane technique, and the main difference is that they don't introduce biomaterials into the jumping gap between the implant and the shield. The same authors also did a study where we can get that in the mid-term follow-up after 5 years, the survival rate and the percentile of integration of the immediate implant with the root membrane technique is comparable to the immediate implants that we have in literature. And they also say that this is a very good way to keep the bundle bone in case of post-extraction socket, even if we have small periapical lesions. They also did a study in 2018 of 2050 immediate implants in 182 patients, and after 10 years of root membrane technique, they saw that the long-term follow-up was very high and compared to the immediate implants that we have in literature. This article is the one that I want to show you because is maybe the one that is not talking very good about the socket shield. I mean, they are actually asking if there's enough evidence to prove the efficacy of the socket shield. And actually, Muria and Al, what they did, they took all the literature about the socket shield and they exclude many articles because of complication that we'll see later, and even a small complication they excluded the article from the systematic review. So actually they kept only 21 article, from which they described at the same time that um, some indications of the technique. So they say that from this article we know that the root thickness of the socket shield has to be from 0.5 to 1.5 millimeters in the 21 articles that they kept, and that were most of them were about the root membrane technique, and the graft was not so important to maintain and to form new bone um, in the gap between the implant and the shield. But still, if the gap is more than 1 millimeter, it suggests to use the biomaterial. So let's look what are the indication and contraindication of the partial extraction therapy. We already saw in the root submerger technique that were intact buccal wall, stable immobile shield, no intrabony periodontal defects, and small periapical lesions. Of course, if we have big periapical lesions, we have to think that is not a problem if we can reach primary stability of the implant. If not, we can, of course, keep the socket healing and with the biomaterial and or collagen to keep the three-dimensional architecture, and then we can go with the delayed implant after 2 or 3 months. Contraindication are loss of some of the buccal bone. For example, if we have resections and or a damaged buccal bone, we have to avoid the socket shield technique and go through a GBR, a typical GBR technique. And of course, if we have periodontal problems of the root, we cannot go through the socket shield technique. Also, if the tooth mobility is higher than 2 level, we have to avoid the technique. We have also a relative risk, that is when we have external root resorption. Even if the resorption is not in the shield that we want to keep in our surgery, this is a relative risk that we have to think about very well to if we want to go through the socket shield or not, especially in a very high aesthetic area. The complication. The complication actually are all about the shield. The shield can be displaced during the procedures or later, but later we can say that is going to be happen if we didn't be careful to realize how stable was the shield. So in literature, if the shield is stable and well trimmed and the apex is right, and we insert the implant in a good way, the technique is very predictable. Then we can have the shield fracture. Even this complication is during the surgery usually, because sometimes we can insert the implant, and the thread of the implants going deep into the bone can go in contact with the shield and crack the shield, and this is a complication that we should be very careful to not do during the surgery. And in my opinion, especially from the beginning, where we were used, the authors were used to keep the shield 1 millimeter above the crestal level, and the shield exposure were more common. But now that we trim the shield until the bone level and maybe 0.5 lower with the bevel, and we left, and especially if we leave the space between the prosthetic element of the implant and the shield that has to be 1.5 or 2 millimeters minimum to let the soft tissue heal in a better way. This shield exposure is more rare. This is an example of one of my cases. I did an immediate loading in canine area and the two premolars, and I did the socket shield in the canine area. These are the images of the post-surgery, the suture, the temporary abutment, peak abutment, and because I wanted to give immediate loading to smile to the patient, the OPT post-op, and these are the temporaries that I did cement above the implants. This is right hand after the surgery. But 5 months later, when I had a look of the CBCT, because I had to insert two implants in the molar area, I saw that the shield was perfect, all the implants were osseointegrated, but going deeper and looking at the marginal level, I saw a shield exposure. So what I did, in literature, the authors suggest to use a round diamond bore to trim the shield until we reach the crestal level or in deep into the soft tissues. If this drilling is huge, we can also use connective tissue graft to enhance the volume of the soft tissues. In this case, I didn't have to, and we can see how the concavity of the canine area is maintained by the socket shield. So I inserted back my temporary abutment and went go through the other surgery that was planned for that day. One important things to say to avoid all the complications that we can have during this technique is the guided surgery. In this article of 2020, we can see that we can actually use two surgery guides. One is to reach the apex and maybe go through the apex, especially if the apex is not close to the buccal aspect, so is the inclination of the root is not too much buccally. So the first surgery guide is used to do the most difficult step of the surgery, that is to reach in a conservative way the apex and then to work around this area on the periapical area of the implant. And the second surgery guide, is used to insert the implant in the perfect three-dimensional position. So during my studies and clinics in these less than 2 years, I did 44 partial extraction therapy, and I did 3 partial extraction therapies in molar area. I did one socket shield in plus CTG in one case that we'll see later, and some of them were immediate loading, some of that were delayed loading, and I did the 3 cases of Pontic shield. One of them is became an implant after 3 months. We'll see later because is a clinical case where I did a Pontic shield, then I did the implant, but still is the same case that where I did one of my 3 mistakes during these procedures. So one mistake was to not clean very well the apical region, and then we'll see later. And then I did also another mistake, that is not to cut perfectly in the mesial distal aspect of the root. So when I went to extract the lingual part of the root, actually I removed all the root. So it was a case of two premolars with the immediate loading, and I planned to do two socket shield, and finally I did a socket preservation on the second premolar, and I did a socket shield and immediate implant in both of them, but one with socket shield and one with socket preservation and biomaterial and immediate loading. The third mistake was that during the preparation of the socket shield, I didn't realize that the buccal aspect, the shield, was not bone supported. So when I was separating the two parts of the root, the buccal aspect was moving. And so actually I use that like autogenous rigid membrane and biomaterial and insert an implant to perform a technique that is called fly socket shield, but is not a technique that we're going to talk about in this webinar. And actually I'm not so expert because I did only that case. So let's go through our first case. Is Elena, that she's a patient. She's a young lady and beautiful lady that she went to our office with an emergency, and she had to extract the second premolar. So I had a look of the X-rays and carefully, and I was looking carefully at the pre-op CBT-CT scan, and I saw that it was not the perfect situation to perform an immediate implant. So I said to the lab, okay, I'll taking an impression, and please do to me a Maryland bridge, a temporal Maryland bridge, to give the patient a smile when she go out after the surgery. So actually I started to prepare my socket shield, and okay, and I started to trim the root until I reached I thought I was reaching the crestal margin, but I was maybe 0.5, 0.8 above the crest, and I was sure to clean all the periapical area. And so I said, okay, let's do the Clocker technique. We can insert the collagen and the suture, and then I can cement a Maryland bridge. These pictures are right after the suture removal, 7-10 days later, and after 3 months, this is the situation that we can have, that we had after the healing of the alveolar socket. When we can see that buccally the profile is perfect, like it was the time zero. So after 12 weeks, the CBCT, the three-dimensional aspect of the bone was perfect. I saw that the shield was already still there, but yes, I saw that the shield has to be trimmed a little bit more. But then when I saw the sagittal slice, I saw that the inside of the socket there was no bone formation, and the reason for me, and I'm pretty sure, is the reason is it was that I left a little part of the apex, not really a canal, but the apex, and a little bit of periapical lesion that is around the apex of the root. So what I did, I enter again in the area, and I went to remove of the tissues inside. I was correcting everything, and I was very careful to remove the apex that I left on the first surgery, and I trimmed down to the crestal level the shield. After that, when I was this time very sure I was cleaning everything and in a good way, I used my osteotomes and the magnetodynamic technology to perform a crestal sinus lift. And this time I went apically to get a cortical stabilization where I did the crestal sinus lift. So I insert the collagen and the healing abutment, and I cement for the second time my temporary Maryland bridge. Here are the images of the cementation. This is the OPT post-operative. And here we can see that actually I reached the stability in this area, and I did a little bit of crestal sinus lift, and I kept stability, primary stability in this area. After 6 months, um, this is the situation after the removal of the Maryland bridge, and this is the CBCT that I wanted to do because I wanted to be sure that this time the bone formation went through a good way. And fortunately, this time the bone formation was okay, and apically where I did the crestal sinus lift, I had new bone formation, and we maintained the bundle bone buccally to the root. Here, this image for me is the best way to show you the potential of this technique. Because if I have to ask you from this image if you can guess where is the implant, it is very difficult. Of course, here you don't see the root, but if you look from here and apically, you cannot really recognize, especially in this part of the bone that is peculiar of the patient, you cannot recognize where is the implant. And this is for me the best characteristics that we have in this technique. That is where the same thing that I was saying at the beginning. That is the best thing to preserving what we have at the beginning point. So we actually don't have to reach the restitutio ad integrum, but we keep the integrum. So we can go through our prosthesis, and this is the peak transfer of that B&B has a beautiful system to take snap-on implants, and I love those transferred very much. So we took the color of the patient, and then we could deliver the final crown, and this is the image of the transmucosal portion and the final abutment at time 0. The final crown at the time 0 of the delivering, and this is a buccal aspect, but still we can see that we maintained the volume buccally. The patient is very happy because she looks like he never changed her crown, and this is the RX after 6 months, and the final crown in place after 6 months. So the best way is to compare the situation from baseline to final, and with no biomaterial, with no big surgeries, we did maintain the original three-dimensional structure of the bone of the tissues of the patient. Second case I want to show you is Riccardo, and he had a fracture of the lateral with also a periapical lesion, and here we can see that we have the periapical lesion, but still we have bone apically to the root. We have a very thin buccal bone. Here we can see very well, and this is also the reason why I decided to do a socket shield technique, but also I decided to use a connective tissue graft to enhance the quality and the aspect of the convexity of the labial part of this lateral incisor. So this is the beginning of the case where I saw the fracture and I removed the post and the crown, and this is the profile that we can see here. The profile that is not convex, but not concave, but straight at the level of the lateral, and we see that the biotype is thin in this area. So I started to drill to trim the root in a apical direction, and I was lucky because I ended with no fractures, and I kept all the shield here, even in the interproximal area. Of course, the space is very tight, so I used first the osteodensification drills, and then I insert the implant that is pretty close, is 0.5 in the more coronal aspect, but then is going to be larger going apically, and I went 1.52 millimeters above crestal bone in the palatal aspect to allow the prosthesis components to have their space for the soft tissues. Like I was saying, I took a CTG from the premolar area. I know Zucchelli is not happy to take from the premolar area. I know it's better from the molar area. The quality is better. We have less epithelialized tissues, but I wanted to keep all the surgery very close to the same area. And also I needed a small quantity of tissue. So I took CTG and I opened a partial thickness flap buccally, and I insert the CTG using only fibrin glue and no sutures. Then I used a temporary peak abutment and some Teflon inside of the gap to avoid the migration of the resin inside of the gap, and I used the original ceramic crown rebased with resin to keep the same aesthetic for the patient during the healing period, and this is right after the surgery. We can see that already we did enhancement of the convexity of the labial aspect of the lateral incisor, and this is just right after the surgery, and the last X-ray and the X-rays just after the surgery. And now we are at 5 months, and from the very dramatic situation of the beginning, we now are at this point with the osseointegration of the implant, good soft tissue health, and a new convexity. I'm sorry. Buccally in the buccal aspect of the lateral incisor. Another cases is the case that I want to show you is Alessio, and Alessio had to extract the three root in 23, 24, and 25 position, and his treatment plan was not to insert any immediate loading, and Only the extraction came to the office to do the extraction, and I had to do only the surgery. So I wanted to understand what could I do with this patient, and I had a look of the CBCT, and I saw that in the canine area, in the 23, I had apical bone, and the same, less but same apical bone we have in the two premolars. The second premolar, the 25, has a very huge diameter in the palatal buccal dimension, but still a little bit of apical bone that we can use, where I could use osteotome techniques to perform a little crestal sinus lift. So I did like Dennis Tarnov say, one miracle at the time. So I started to decide which is the correct position to insert the implant. And so I did utilize the drilling through technique to insert implants in the right prosthetic position, and I utilized the root to understand where is it the right position. So I started with high speed drills, and then I used the lance drill of the implant system, and then I inserted, and I found it with and I reached the 2 millimeters drill situation in the last image. So at this point I was able to remove the palatal aspect of the vestibular of the buccal roots, and I was able to use the magnetodynamic technology also to luxate and extract in the very easy and rapid way the buccal fragment of the roots. And after that, I used the screw bone expanders on the canine and on the first premolar, and I used the osteotome technique on the second premolar to perform crestal sinus lift. And I was able, this was the second miracle, to insert the implants. And from the central image to the right one, we can see that I trimmed the shield deeper until to reach the crestal bone level, and I inserted the three of the implants. And then I used the root membrane technique, so I used to insert only collagen, and I used collagen, pressed collagen to perform a poncho technique that used always used my friend Alberto Miselli, and he used and I was able to screw these healing abutment that are a conical healing abutment with a conical connection. So you reach the first stop and then the second stop to go through the conical connection. And where we see now collagen, I was waiting to see in the next months new keratinized tissues. So this is the OPT post-op, and we can see the healing of the soft tissues from the first images that is taken 22 days, and the second image that is the final healing of the soft tissues. When we look at the CBCT, of course, we can see that everything is going well. The bone is still preserved, and the buccal aspect, we can see the shield with bone between the shield and the implant and the buccal aspect. And where we did the crestal sinus lift, we see bone until the apex of the implant. So this is these are the pictures right after the unscrew of the healing abutment, the day that we took the impression to deliver then the abutment and the provisional. These are the peak transfer, the snap on peak transfers, and at this point we were able to deliver the permanent abutments and the temporaries. At this time, my work is done, and the prostodontist can continue the modeling of the soft tissues to then deliver the final prosthesis. This is the inside the intraoral pictures of the temporaries, and the patient is very happy. But finally, I want to show you what we achieved with this technique, with this very conservative, flapless, no biomaterials, very minimally invasive technique using even very few drills, only until 2 millimeters. Then I used bone expanders, osteotomes, and sometimes I use osseodensification. So everything, and the socket shield, everything is working to give us the best solution to maintain the integrum that we have before the tooth extraction. So with this slide, I want to thank you. I want to thank you for being until now with me, and I hope to have give to you all the indication that we can have to perform this technique. Of course, um, we have to. If I want to give a take-home message, this technique for me is the best way to maintain the original aspect of our patient, but is still a difficult surgery if we think at the first article of Daniel Boozer that I was mentioned at the beginning. But still, we can learn how to do it gradually. And my suggestion is to start from an extraction where, for example, we have to keep a pontic area. So at the time, and not in an aesthetic area at the beginning. So with this, we can start to practice and with the minimum risk, because if something goes wrong, you can go through a normal socket preservation with the biomaterial and membranes, like we all do every time. So thank you again, and see you, and my best wishes to you, all of you, and see you soon. Bye bye.